I have the pleasure to introduce our speaker today, Dr. Barouqa, who is a well-established pathologist. He did his residency in Albert Einstein, and then he did his hematopathology fellowship at not so far from here at Mayo Clinic. And then we got introduced to each other when he was doing his second fellowship at Cleveland Clinic. And he is also one of the up and coming on the power list of pathology in 2022. And he is very well established in the research area as well as a pathologist. But also, I would want to say that he is even a greater human being and a very good friend of mine. We were actually studying with each other for our hematopathology boards while I was doing my molecular fellowship, and he was doing his blood bank fellowship at Cleveland Clinic. And without further ado, I'll give him the mic to start his presentation.
Thank you very much, Ish, for your kind words. I'm really flattered, and thank you so much for this very nice introduction. I really appreciate it. And thank you for everyone at your department for having me this morning to talk about the NETs, which is the neutrophil extracellular traps. And this is a project that I started when I was a PGY2 after a call when I was covering the CP call at Albert Einstein. And it started with an idea of a clueless resident looking into something that is not knowing what I'm looking at and freaking out about what I'm going to do next. Should I report it to the clinician? Should I call it a critical value and call the patient? And in that case, it was the patient family because it was a pediatric patient. And then that project led into many other questions. And with time, it was one of the projects that we took us 4 years to publish. We kept publishing during the 4 years about our findings, and even now we are working in the same domain with multiple institutions to identify those cells. So for conflict of interest, I have none to declare. And for our outlines today, we're going to start with an introduction, what the NETs means, how we can induce them and detect them on peripheral blood smears and in the lab. What are the results that we had when we did the experiments that at Albert Einstein and later on in Cleveland Clinic, and the use of artificial intelligence in detecting those cells. And at that point, my goal was to get a patent or make a program and make billions of dollars so I can go for retirement somewhere on an island in 2 years. And apparently, as you see, I failed because I'm still working. And we patented, but we couldn't. It is not something easy. Later on, we figured out that to sell any application like this. And then I will talk about the conclusions that we have from our research. So the smudge cells, also known as basket cells, are very common cells that we see them most commonly in CLL, SLL patients. And usually the smudge cells, when you see them on the peripheral blood smear, the more you count them on the smear, the better the prognosis. And the group at Mayo Clinic, they published that the percentage of more than 30% of smudge cells on the peripheral blood smear is associated with more favorable prognosis when compared to less than 30%. And they reported a percentage of 80% versus 50%. And as you know, it is this smudgy kind of artifact-like cell that you see that indicate that there was an atypical lymphocyte that during the preparation of the slide, the smudginess caused the formation of this basket cell. And usually CellaVision, which is an apparatus that is attached to the autoanalyzers, the peripheral blood autoanalyzer, it has the capacity to take multiple photos of a lot of the cells and start counting them. And the process usually, or the workflow of the specimen, is that once you run the CBC in the Sysmex itself, it goes to to a special instrument that will prepare the peripheral blood smear, and then the peripheral blood smear goes to CellaVision, and CellaVision will report the cells, and it has the capacity to identify them. However, as you see here, smudge cells and the other cells are classified under the same category. So basically, if it doesn't know what it's looking at, it might put it under other. And if it sees something like this, like a smudge cell-like, it will call it a smudge cell. And back to the call back in 2018, the call that I got was for a 1-year-old patient, and the lab called saying that they are reporting a lot of smudge cells, and they think that this might be a CLL case. And at that day, during that night, back in my mind, I was like, if this is not a USMLE step 1 question, then we really have a big problem in the lab, and I don't know what we are looking at. So rushing in back into the lab, looking into the peripheral blood smear, we were able to see this kind of cells. And one thing that I noticed is that they are either coming from neutrophils or they look like a smudge cell, but if you look into the morphology of the cells, are quite different. There is a lot of vacuoles inside them. There is a lot of this material, like the cell is trying to form a big web. And it is, if you compare it to the size of the surrounding cells, it is actually either a little bit larger than the red cells, and some of them, they were even bigger than that. So back in my mind, I was thinking, if this is a true artifact, and they are definitely not a smudge cell, and therefore, the next thing that I did is to call my mentor at that time, Dr. Moraima Reyes, and asking her and showing her the cell. And at that point, she told me those probably are the neutrophilic traps. And from there, we started the project. So what are they? The neutrophil traps, or the neutrophil extracellular traps, also we call them nets, or sometimes called the web-like smudge cells. They are part of the innate immune system. And usually our neutrophils regulate our innate immunity either by phagocytosis, as we all know, by the generation of reactive oxygen species, sometimes by degranulation. And in 2004, the process of netosis was discovered. And a full mature net, if you look into at the peripheral blood smear, you can see how big it can be compared to a red cell. And then you can see a lot of the vacuoles and a lot of this. This is actually the chromatin and the DNA material that is trying to form a web inside the peripheral blood. And the morphology keeps changing as those cells keep aging. And therefore, knowing or identifying certain morphologies can actually give you a certain indicator for the trigger of the stress that caused them to form. And the formation of the nets has been described and has been studied, and until now it's being studied extensively. And there are a lot of proteins. If you look into the literature, there is a lot of different mechanisms, but currently there are 2 mechanisms that include those proteins that you see on the slide, that everyone agreed that this is likely the process of their formation. The most common protein is the serine protease neutrophil elastase, known as ELANE. This is the key protein right now, and the other proteins also are very important, but ELANE is currently is being the focus of the study. And the focus of this study is that, as later on I will show, that the ELANE, if we can control it, then you can control the formation of nets. And nets, it's true that they are part of the innate immune system, but if they go uncontrolled, they can become pathogenic too. So the processes of formation of nets depend usually on the trigger that is going to trigger the neutrophil. So the most common pathway is actually the first pathway that you see here, which is the slow cell death, or that is known as the netosis. And it is basically mean that there is going to be a slow process because the trigger that is causing the net to form is not, I would say, it is not very acute. And therefore, the cell will start with a nuclear delobulation and then deassembly of the nuclear envelope. And then the cellular depolarization and the chromatin decondensation will allow the chromatin to start attaching itself into the granules inside the cytoplasm. And then the plasma membrane will start dissolving and rupturing, and the net will be released. Now, if the neutrophil is exposed to something that is more acute, like and most commonly it is the Staph aureus infection that will cause it when the patient is about to get into the septic phase, then there will be a rapid response from the neutrophils, and this is known as the non-lytic netosis, because mainly it means that there is going to be a condensation of the chromatin and a very rapid expulsion of the chromatin outside, and this will allow the neutrophil to form the net, and at the same time to maintain their phagocytic cytoplasm, which will contain some of the remaining granules inside. and those granules and the phagocytic cytoplast will add an extra mechanism of defense in the blood in order to combat the stress that the body is trying to cope with. Now, the formation of NET, in a sense, when you look into the idea of their formation, you would think that they are doing a great job, that they are helping the body, that they are supposed to be protecting the body. And that's true as long as the process is controlled, as well as the process is under certain, I would say, going through a certain process and is timed. But a lot of the illnesses and a lot of the inflammation process and a lot of the tumors that were studied in the tissue, it showed the presence of the netosis or the presence of those neutrophilic traps actually in a way where they are contributing into the damage. And that's because they go uncontrolled. So for instance, if you look into the tissue cell here, you can see that there is a tissue cell, that the NETs is causing the cell damage to happen. And this is a very common thing to be seen in sepsis and autoimmune diseases, in diabetes, especially if cultures that were taken from chronic wounds from diabetic patients showed on the tissue level the presence of a lot of NETs, which indicated that actually the continuous release of the granules and the reactive oxygen species is causing damage rather than helping the body. Also, in the process of inflammation, where they were found to be related to the tumor-associated inflammation, to organ damage, to even ischemia, and to the cancer-related ischemia. And on the level of the vasoocclusion, they are also related to the formation of thrombi. They are also related to coagulation in cancer and pancreatic duct occlusions. And actually, the vasoocclusion is not currently our next focus in our study that we are carrying out to see how they are contributing to VTEs and the vasoocclusions. Another thing is that they have the capacity to metastasize a cell. If the neutrophilic traps responds to a tumor cell, and for any reason the tumor cell resists the NET, they have the capacity to circulate that cell, and therefore they may allow the metastasis to happen at a very high rate. And also they are related to the autoimmune diseases, where they were also associated with the formation of autoantibodies. They have the capacity to release interleukin-1s and other mediators that have the capacity to cause acute attacks of gout. Now, on transfusion side, which is my domain, the NETs also on a lot of mice models that were studied at different institutions that included University of Alabama, it was found that in patients with the TRALI, the transfusion-related acute lung injury, platelets contribute to the TRALI by allowing the formation of NETs to occur and to happen. And in this study, you can see here that this is a control tissue that we took from the lungs of mice. And this is a control normal mice, and with the staining with DNA and MPO and histone, which will catch those NETs, and staining for platelets, this is a CD41 stain. This is what a normal tissue should look like. Then when we induced TRALI itself, we were able to see that there is an increase in the DNA material, because remember that the neutrophils, when they form the NETs, they are depending on the DNA material and the chromatin to allow the formation of the NET, and for those to become the sticky web to carry the granules and increase the surface area of the neutrophil. So basically, we were able to see that the MPO and the histones also were picking up a lot of those neutrophilic markers, and also there was an increase in the platelet count, the platelet infiltration into the tissue. And the next step that currently they are working on is to see how aspirin can affect and can inhibit those platelets, and see if it can actually prevent the histone and the MPO. Now, TRALI in general is not a big issue right now. We don't see it that much, because in 2004, we have shifted our use of plasma into male donors only, or into female donors that are tested and were non-pregnant, so that we can avoid using or avoid TRALI to happen. However, when it happens, the patient needs to be admitted to the ICU. They need to be intubated for 96 hours. And therefore, if these studies shows that we can prevent it by just stopping the NETs or just by reducing the severity, that will be a major breakthrough actually in the field. And one of the studies that actually looked into the nets was one that looked into TRALI and compared it to the COVID-19. Now, it is still controversial if nets are part of the COVID-19 or the part of the COVID lung injury. But one study that was published in 2022 showed that the use of disulfiram can prevent the formation of nets, and therefore they started using it for the COVID patients and for TRALI patients. The data collected from TRALI is not very extensive in order to establish that there is a true effect of disulfiram, but for COVID-19, it's very weak, and that indicates most likely that the nets do not have a major part, I would say, or direct part in the COVID-related lung injuries. And for the infectious parts, the nets are related to many infections, and in the tissue, the streptococcal infection and staph are the most common ones, but also they were related to many other microbes, fungal infections like mostly the Aspergillus infections, as well as the autoimmune disorder, thrombosis, cancer, and the biggest one was the sickle cell disorder or the sickle cell disease, where they contributed to the vasoocclusions as well as to the acute chest syndrome. So the first thing that we asked ourselves back in that day in 2018, are we looking into something that probably will look like an artifact? And the first thing we tried to do is to make sure that this is not an artifact because of the formation or the preparation of the slide. So we started with the sample processing, and at that time we used normal subjects. Basically, it was me and Dr. Reyes and some of our colleagues that volunteered to give their blood. And we started sampling the peripheral, preparing peripheral blood using different collection tubes. We used different temperatures. We used different sample stabilities. Then we went to the smear itself, the machine that will do the smearing itself. We changed the force and we changed the angle of the smear and the angle of the cover slip. So basically, the instrument works is that it takes a drop of blood, put it on a slide, and then it automatically will smear it. And we started changing the angles because this is something we can do. Also, we changed the force of the smear itself to make sure that we are not inducing them by the process itself. And also, we asked our colleagues in cytopathology to smear some of the samples for us, and all the normal samples did not show any formation of nets when we ran the slides in Celavision. And this is the instrument, and just to show you the Sysmex, how it works. So basically, we run the CBC here. This is where we will do the smear, and the Celavision will work and take the photos. Then these photos can be accessed by any computer in the lab. Now, knowing that at that point that what we are dealing with is not actually something related to an artifact, we started thinking of inducing them in the lab. And we used PMA, LPS, and calcium ionophores, which we found in the literature, in the old literature, to have the capacity to induce these cells. And the PMAs, LPS, and the calcium ionophores, actually, they are very, very similar to the mediators that are used by the gram-negative bacteria in sepsis to induce the formation of these cells. So basically, we started following the normal samples, as you see here, at different periods of time, and up to 24 hours. And every 2 hours, we will do a peripheral blood smear. And then we've added another tubes simultaneously with PMA, LPS, and calcium ionophore from the same on the same blood specimen that we split into 4 different tubes. And then with time, you can see that the nets are, or the neutrophils here on the normal non-induced sample, they are stable. But looking into the PMA and the LPS and the calcium ionophores, the neutrophils after 2 hours started the process of condensing their chromatin and DNA material, and the vacuoles started appearing. And then later on, you can see that they started actually to form the neutrophilic traps. The same thing happened with the LPS, and the same thing happened with the calcium ionophore. Another thing is that the morphology keeps changing, and that means it looks like that the neutrophils, they are dissolving, and therefore, at 10 hours, you can see, after 10 hours, you can see that the morphology is between the LPMA and the LPS is quite very similar. The same thing goes to 24 hours. And the same thing when they probably started the process of formation. And that means that there is an element of aging onto those neutrophilic traps depending on when on the exact time when they were induced. And in order to prove that what we are looking at is a net, we used stains, and we used first the citrullinated histone stain, which is a stain that picks up the neutrophil extracellular traps on the nets by staining the DNA. And here you can see that it picked up the DNA itself that is present. And the same thing when we did the staining with the PMA after 3.5 hours, where the stain, I put it just in black and white just to show the formation of the net. But also when we repeated the staining with MPO on the same cells, we were able to see that they are positive, and therefore they are PMA positive, MPO positive, indicating a neutrophil that is activated and formed the net. The next step in our approach after we induced them on peripheral blood and we were able to see the morphology is actually to use the Sysmex itself, the one that runs the CBC, in order to detect them. Now, the way that Sysmex works is actually by forming a scattergram. And therefore, when you run your CBC, the Sysmex will do a fluorescence against the site scatter and will do a forward scatter against the fluorescence. And it will detect all these cells, it will enumerate them, and after that, it will report to you the CBC report that we all see. And the goal here was to actually find if they are hiding somewhere behind the white blood cell gates, or we can actually have a new gate for them and where we can detect them. And in order to do that, we actually repeated the same approach that we did for the cells when we looked under the peripheral blood smear. And that means we repeated the same testing using normal LPS and PMA-induced samples from the same donor or from the same subject in the research. And we started looking and running the scattergrams, and we were able to see that after 30 minutes, we started seeing a new population of cells that are detected on our scattergram here. And according to that, we were able to predict that this is probably is the window or the gate where we will find them if they are being induced. So this population here, the one next to them, is your white blood cells, and the blue one here, I don't know if it's a little bit, if you can see it, those are the red cells. And with time, we were able to see that the formation of those nets is happening, and therefore we had a gate where we can follow them. And in order to prove it, we went back to the same samples, and we were doing a peripheral blood smear after we run the scattergram, and we were able to see them and stain them with the stains that we used for the nets, and all of them were positive. So for instance, the cytoxgreen here, it's picking up two neutrophils that are not activated, and in between of them, there is your net sitting in between the two. However, one of the things that we had in our mind is that how we can make sure that we can add more markers and to prove that what we are looking into it, or the cells that we are looking at, are actually the neutrophilic traps. And we are not just detecting something like a degenerated lymphocyte, though they are not going to be in that area or in that gate. And we are not detecting something that is probably we induced in the lab, or something that we are just basically that we are not being misleaded, and also to find more markers to help us if we need to do more flow on it. And in order to do this, we looked into the samples that have less than 5% of smudge cells in Sysmex, because this is the normal level that Sysmex will allow. And then we picked up specimens that have more than 20% degenerated lymphocytes and more than 20% of net. Those samples were reviewed by hematopathologists in the department, and they said those are the degenerated lymphocytes, and those are your nets, and those are the less than 5%, and they got verified. And then we used different stains. We started with the cytoxgreen. Cytoxgreen actually has the capacity to detect any kind of DNA, and it wasn't very helpful for us in this case, because the degenerated lymphocyte actually picked up a lot of the cytoxgreen. But when we did the surface MPO and the CD66B, which is CD66B is one of the indicators and the markers of activated neutrophils. When we looked into the net, the surface MPO was positive when we compared it to the degenerated lymphocytes, and the surface MPO of the control group, as well as the CD66B, was quite positive, as you see here. The CD45, it was positive in both of them as expected. But we were able to use the surface MPO and the CD66B, which was the only thing available for us at that time, to start actually confirming our results by flow. And back to the scattergram, just to show how useful they can be in certain cases. Now, remember, this was our gate that we detected, and here you can see a controlled sample of less than 5% smudge cells. Nothing is there. Those are nets, and they were sitting here, and you can see those were the neutrophils that we were able to see. And those were nets because if they were degenerated lymphocyte, the key for them is actually the degenerated lymphocyte in CLL patients or any patient usually have this kind of extension, and they do not extend into the gate that we identified. And also, when we compared it to the normal subjects, which was our blood in the lab, it was also the gate wasn't that. When you compare the three gates together, you can see that there is a difference there. But the scattergrams, there's a lot of publications about them where they show you how they can be sometimes useful and certain entities to look into the pattern, and they will help to drive the diagnosis if they are available in the lab. Now, the next step that at the lab level, we were able to do a lot of work, but how we would correlate them clinically. What do they mean? How can we use them in something useful? And at that point, we wanted just to make sure that what we are looking at is not just inducing a neutrophil, but actually something that is similar to the population of patients that we are dealing with. So we compared our findings and on the side of morphology as well as the scattergram with a patient that presented at that time with UTI and septic shock and leukocytosis. And as you see, the comparison between the morphology of the neutrophil between the nets is the same. And also we have the same formation of nets in the same area or the same gate itself. And from that point, we focused our efforts into working with patients with sepsis and with bacterial and viral infections, because nets are pertinent to a lot of things. And at that point, we were like, what is very important for us right now that might help us in the lab as well as help our patients? So basically what we did is that we collected the specimens from 394 patients. And then we asked our team of hematopathology to look into the peripheral blood smears and to classify them. So the first thing that was to classify if we have less than 5% smudge cells, and those, they will be called neutrophils or nets within the reference range. And then we formed another group, which is more than 20%, and we asked our hematopathologists to classify them into either neutrophilic traps or into degenerated lymphocytes. And the team of hematology, they were reviewing the demographics of the patients, the CBC, and the presence of microbial infections, where we were trying to detect the first incidence of the microbial infection and when sepsis happened. And according to this, we started with two groups where we compared those that just had a very high level of smudge cells, more than 20%, regardless whether it is degenerated lymphocytes or nets. And we only had one patient that had degenerated lymphocytes, while all the others, the 193, they were actually nets compared to the control group. And we were able to see that when it comes to infections, bacterial infections and viral infections, they show a lot of difference. So basically, that was in parallel with our thinking, is that whenever the patient gets into the point where there is a sepsis or septic reaction to the infection, there is an induction of very high levels of stress in the body that will cause the formation of nets to occur. And then we took it in our analysis to a much more deeper levels. And here you can see that the first thing we looked into it, that we carried out a t-test, and we compared again the bacterial infection and the viral infection between the control group, which is the less than or equal 5%, to the smudge cells as a whole, which was statistically significant. And then we compared it, the control group, to the group of nets, and that showed the presence of clinical significance, as you see here. Now, when we did that, we had to get another set of patients and do the studies. And what caught our attention is that the changes in the neutrophil count, as well as the white blood cell count that you can see here, was not that high. And even when we went back to the first group, and if you look into the white blood cell count, you can see that there is no difference, there's no statistical significance, meaning that the response to and that's a hypothesis that we are currently trying to investigate more, is that the response to a certain stress in the body or to a septic reaction in the body is actually happening in the neutrophils faster than the bone marrow capacity to respond. Because the white blood cell count was still within the same range. It was normal, but the nets were there and they were significantly present. And this makes sense because the neutrophils are already in the circulation. And if there is anything foreign for them in the circulation, they have the capacity to respond faster than the bone marrow. And therefore, this might be a very useful thing to see in the lab in a patient that present with fever or present with fever of unknown origin, and the clinician think that they might have sepsis. This can be an indication that when you start seeing them increasing in number, that probably the sepsis is on the way. Now, the next step that we did is that we wanted to do an artificial intelligence platform. And according to that time, we didn't have a lot of platforms like that time. And according to the FDA, it was very, very strictly regulated. At that time, the FDA rules were to not to use anything that is not supervised, not to use any kind of we call it the extrapolations of your or the automatic augmentations of your models. So we were basic a little bit, and we just went with Python to do our first convoluted neuronal network. And then we took it to our studio for just to validate and verify that what we are looking at is correct, is true. And then we took it to a commercially available platform that we found, and we ran the images between degenerated lymphocytes and between a net and the neutrophil, and the accuracy of the three models were more than 98%. We used 256 by 256 pixel cells, and we ran 4,000 iterations. And it was just a small algorithm that we tried to add into the lab in order to tell the two differences, because as you see, the CellaVision was putting everything under other. And therefore, it wasn't telling us the difference between a true smudge cell or basket cell versus nets. We applied for a USA patent later on, and in 2022, took 4 years, but we were able to get the project patented. And then we applied for a world patent, which took another year for us. And we patented both of those, both of the artificial intelligence idea and how to differentiate the net versus the degenerated lymphocytes using the peripheral blood smears. During the 4 years, we also managed to put some publications out because we were going by phases. So basically, those two are actually the what I presented right now. Dr. Francis Keddy, he's one of the hematopathologists at Johns Hopkins, and he was a fourth-year resident when I was a second-year resident. He also continued working between Johns Hopkins and Einstein, and he expanded his work actually to include the eosinophilic extracellular traps in Hodgkin lymphoma, and also he studied them in the bone marrow. And our hematologists also, they were able to establish the connection between the nets and the sickle cell disease patient and the pathogenesis, where the acute chest syndromes and the vaso-occlusions were contributed to the nets. And because we had a very big population of sickle cell disease patients in the Bronx, and therefore they will see the patients on a daily basis, and the samples were always available for the lab to run it for them. Thank you very much.
That was an excellent presentation, Dr. Barouqa.
Thank you.
So I think now we are open to questions. If anybody has any questions, please feel free to go.
Dr. Franzen has a question.
Who?
Thank you very much. I'm a semi-retired pathologist in the department, and I've been interested in the COVID pandemic, and I was interested in what you said about that in relation to the nets. And it sounded a lot like what was going on with the understanding of IL-6 and the hyperinflammatory syndrome that develops with COVID. Has there been any effort to appropriately inhibit the net formation in patients with COVID, or has anybody looked into that?
Yes, the group in 2022 used the disulfiram actually to try to inhibit the formation of the nets in the COVID patients, but the statistical significance was not very high. And
Okay.
that question also, there was a lot of co-founders in these patients because of the COVID itself. So the group that they were looking at was a group of patients with a lot of chronic illnesses. And
Okay.
it was somewhere between, are we dealing with co-founders or not? And even our experience, because COVID was, we were the epicenter at the Bronx for a long time. So we studied the coagulopathies and we tried to correlate them with the nets at Albert Einstein. And we couldn't find, at least for the coag part, any kind of correlation between them. In 2021 to 2022, a lot of the manuscripts out, they believed that the COVID is related to the formation of nets, but later on, after 2022, a lot of the studies started taking one step back and saying, probably we should think about it because there's a lot of co-founders that we need to think about, and nobody would like to commit themselves and say, yes, that it is there. I was on the front lines for the patients, and at one point, like during that time, if someone will tell us disulfiram will work and will save the patient, we will give it because it was a very, I would say we were dealing with something very new. We didn't understand it. So basically a lot of the observations that were there were based on, I just noticed that if I use aspirin and disulfiram, the patient tends to do better. And then later on, when it was taken into studies, they started taking those steps back and say, probably not, this is the true case. So still something going, and we are excited to see. I think there is a big group in New York City at Memorial Sloan Kettering looking into this. And we're waiting for their results because they had the capacity to store all their peripheral blood smears back from 2020, and they have a big archive for this data.
Thank you for the talk. I have a question regarding your study for the patients who had less than 5% nets and didn't have infection. I'm sorry, for the patients who had elevated nets and didn't have infections, did they have other reasons for having nets? Because you mentioned in your early work that normals didn't really have any. And so were there other reasons that were there that weren't infection? And also, I'm just curious for your kid that you talked about at the very beginning, did you have a reason for that number of nets in that kid?
Let's start with the kid. The kid was septic. He had sepsis. When I did the chart review, the medical chart review, he presented with sepsis, and that's what induced the nets. Now, just to talk about the percentages, the more than 20% is actually like when the question is at that point of time, how we would know what is the percentage, because as you see, you have more than 20, you have less than 5. And we talked to our clinical teams and to the colleagues that we have in ID and hematology, and we asked them, how do you look at it? And they said there is not a solid rule, but for them, the way they approach it is that they use those two percentages, and 5 to 20 is a very gray zone that they leave. They usually do not build any kind of clinical decisions on it. So the more than 20% group means that the patient is developing something that is probably related to a stress that the body is having. So the group that you were looking at, actually, they had something else that caused the formation of nets, but it wasn't pertinent to any kind of bacterial infection or viral infection. So they probably were patients that are having a blastic crisis due to leukemia. That might be a patient with MPN. And actually, some of the patients had VTEs. They were presenting with tumors, and they developed a VTE, and that's what caused the nets to go a little bit up. And that's where we needed our clinicians to do the chart review for us, because we wanted a very accurate, like, backstory to know what's triggering those things. And even now we are looking into the VTE, and one of the challenges that we are facing is how we are going to account for those co-founders. We are looking into 35,000 patients right now that we are trying to study. And one approach is to use logistic regressions in our studies, and therefore we will be able to statistically remove them out. But that will also reduce the power of the study, because you cannot control the regression, and there's a lot of linearity that you need to do. And another way is to actually review the 35,000 patient charts, which is quite impossible to do it manually. So the third one is that we are trying to build a platform, a data miner that can do that for us. So we are now building the data miner so that we can actually validate if we have a project or not. So it's very hard, and sometimes just looking into what we have as a data is the best approach to go, like just to have a sample and try to build it from there. Another idea that came from Cleveland Clinic is to use something we call it the chain equations. And chain equations is something that can amplify the data by finding a pattern in the data itself. But we are here using images, and the morphology is also part of the study. So we are not just looking into lab values, but we are looking into images that we cannot just ask any kind of algorithm to start imagining them. So it is very when it is more than or equal to 20%, it is very important that you have another team working in parallel with the lab to look into these data retrospectively, or to start the project and do a prospective study where you collect those patients and you keep them, but also that will take time. So that's why the project took us 4 years to have I would say the first couple of publications out.
Thank you.
Cool.
I have a question. Thank you for that talk. I recall that as a lab tech, when we would see smudge cells, the Sysmex would tell us to do the albumin prep, and that would reduce some of the smudge cells. I'm not sure if you mentioned that, but can that same preparation be used for NETs to see the true number prior to doing any flow cytometry or any other molecular test?
It can be used because if you have the capacity to isolate the two and just make one of them to stand on the slide, that will be very helpful. But the issue, and that is a discussion that we had with Sysmex at that time, is that there's no algorithm or module built in Sysmex itself to report them. So basically, if you use the albumin, you might reduce the smudge cells, and if it keeps the neutrophils traps sitting on the peripheral blood smear, still Celavision and Sysmex won't be able to tell the difference because they are not built into the system yet. So and the reason is that Sysmex will put the argument saying, but why do we need to report them? Because what do they mean? And that's where we started working to show that these cells are very important, and in a very sick patient, you will have having them will indicate that something major is on the way and something big is going to happen. So basically, that's what we are trying to prove in our publication, saying, yes, we need to keep them. Probably, as you said, using the albumin will actually increase the accuracy of looking at them and help us to put a number for those nets as a percentage. But unfortunately, until now, the significance for a lot of the companies is they still don't see it.
Thank you.
You're welcome. Because I mean, just also to build on your idea, if you can use albumin and then you can report the neutrophil traps as one of your parameters, like hemoglobin and like lymphocyte percentage and monocyte percentage, then the clinical team will be able to build some conclusions and say, okay, I'm seeing a trend here where the neutrophilic traps, the true one, are increasing, and there's probably something happening. The patient looks like is having a fever, so we probably will need to start, like, for instance, vancomycin right now, just prophylactically, or we start the culture right now because the patient might develop a shock later on.
So to expand on that, you are saying that by getting the true number of nets, we can trend that to see if the infection has been resolved. Okay.
Because if you think about it, the nets are not going to be induced unless there is something happening. Something is allowing them to get induced in the peripheral blood. So basically, if they start showing a trend for a patient that is admitted to the ICU, that is an indication that there is something significant that the patient is happening for the patient. Now, you will need a clinical correlation, of course, to know what is the most likely to be here. Is it sepsis? Is it the cancer? Is it the autoinflammation that the patient is developing? So all of these things will be needed, but the trend itself will help you to see where we are navigating, especially that it can be a very early indicator before the bone marrow can respond.
Another question on that, have you thought about seeing if the amount of nets also relates to levels of procalcitonin? Because I know that that is also used as a trend in sepsis.
Yes. So basically, at our institution at that time, unfortunately, we didn't have the procalcitonin, and it wasn't done, so we didn't have the chance to do it. But one group at Albert Einstein, they were working actually on TB patients. We had a big population of TB patients in New York, and they were able to detect them in the sputum of the patients whenever there is a flare-up or whenever they are developing any kind of complications. Procalcitonin, we thought about it, but we didn't have it available. It was a send-out test, and also we were limited, I would say, in funds, so we couldn't also send out the specimens. The 400 specimens sent out to a private lab for procalcitonin also wasn't something we can do. But this is a great idea. It's crossed our minds, but we were a little bit limited in our approach, as well as we started in 2018, and in 2020, when COVID hit, we had to focus our efforts towards COVID. So the whole lab shifted its focus and to the COVID and the related coagulopathies for COVID. But after a year after that, we resumed the work. But it was too late for to add anything at that point.
Thank you.
Okay.
Thank you very much for joining us today from Mobile.
Thank you.
And we will talk to everyone soon. Have a good day.
You too. Thank you. And if you have any questions later on, please feel free to email me, email Dr. Reyes. Dr. Henny Billett is one of the people that worked on this project. We are available. Please, any questions, any inquiries, we are happy to answer.
Sounds good. Thank you all. Have a good day.
Thank you.
Thank you.